All right. So thank you all for joining in. Welcome to Professionally Integrated. Uh, we're going to go over tonight. I want to try to keep this a little lighter, a little fun, because this isn't always the most fun topic. I've done other webinars like this, but we're going to go over, I want to give you a couple of examples of a patient comes in with some imaging. Now, we're not going to do a ton of flexion extension, a ton of MRIs, just for time's sake. We could always do another webinar. We've done a couple of these. Um, that are on the site that you can go under webinars and clinical, and you'll see all that. But we're going to start today. And if you have any questions, I'm going to keep trying to jump back and forth. I want you to be ask yourself these questions, talk out loud. The point of this is for you to educate and communicate and document what you find on your patient's images, right? I'm going to give a couple scenarios of here's a real patient. This is what they complained of. Here's a snapshot of an image. What do you say? What can you do to increase the level of your practice? My wife and I, as many of you may or may not know, we have our own practice. We're not in any insurance networks. We don't really advertise. And just the other day, we had 14 new patients call, right? And the goal is not to help you be a personal injury doc. It's to just be a better chiropractor. It doesn't matter if someone's involved in a crash or they're coming to you with no lawyer, which is the majority of our practice, right? We see so many patients that are struggling and need help, and no one else has really been able to educate or document what's wrong and explain to them what's wrong. And then more importantly, how do you correct it? So let's go over a couple of suggestions here, a couple of examples. And I want you to raise your hand to, if you don't want to raise your hand, just talk it out loud to yourself so you hear it. And again, for all of you that are on the site, here's a challenge. It's a simple challenge. If you really want to be better and you really want to learn, you got to fight for it. You got to put in work. You want your patients to get better, they have to do what you're asking them to do. That takes time and energy. Hop on the site just 10, 15 minutes to listen once a week, and then use the site every day in your practice. So let's go over some of this now, and let's get this started here. Okay. And if you want to jump in, you could always, I'll check back, but a lot of you also have my cell phone number. If you don't have my cell phone number, you should get it, and then you can text me. All right, so educate on what your patient's images mean, okay? And I always say this, I know there's a lot of people out there like, hey, they're going to sell. I'm not here to argue if selling works. My thing is, I want you to just be able to educate what your findings are, because once you educate and communicate and get people better, you never have to sell again. So I'm going to try to keep this light. So try to join in, right? I'll check back and forth and ask you some questions, but let's see if we could just find really fun, creative ways to show our expertise, to show why we separate ourselves from all the other practices in your community that are trying to get new patients as well. So what are some of the goals of today? Well, one, let's just discuss some of these patient images. I want you to feel comfortable in communicating what they mean, because let's be honest, if you got to this point, you already sold them. They're in your office, right? I don't know how you sold them. Maybe it was a referral. Maybe they found some coupon or something. I don't know, but they're in your office. So now, why are they there? Like, they have a problem and they want to know, what does this problem mean? Does it correlate to my findings? And is there evidence that actually suggests that these findings do correlate to my symptoms, and how can you help? So just tell me what is wrong. I'm already here. I don't need you to sell me. I don't need you to give me some whatever. Tell me from your heart, from your knowledge, what do you see? And how does this relate to me? And feeling comfortable in doing so. And then I want to show you also quickly how to use the site to quickly find what you're looking for, to show and educate your patient how I use it every day on every single patient. I don't care if it's a PI patient. I want them to be as informed and educated as they possibly can with using the site. And then I want to just help you build a referral only practice where your practice is full and you're not spending any money on any marketing or anything. You don't have to give away your care. You don't have to give coupons and Groupons, because you're given the level of expertise. So today we're going to do mostly images. Let me just see here, because I think someone has a question. Use Posture. Someone's asking if I use Posture, and if so, do you use a report or the unmarked images? Great answer, and I'm going to show you. I do use Posture A. I don't have anything to do with that company other than I use it, and I show them the marked, and I show them more than that. And I'm going to show you. So thank you for that question. So what do the images show? And then after it shows, what does that finding mean to the patient, right? So you could say, oh, look, here's your neck. It's not good. This could be a subluxation that leads to neurological dysfunction. Okay, well, how does it relate to that person? Is there a finding on there that does relate to that person? And then how does it relate to them, not just for their symptom today, but does that finding mean something in the long term? And that's what we want to know, right? Think about it this way. You go to a cardiologist, and I've used this analogy a ton on the site and in court, and the cardiologist looks at you and you have high blood pressure. They want to manage that long term. Don't we want to do that with spinal subluxations? Do true spinal subluxations as true pathologies that we treat every day? If they're not removed, does it decrease the quality of that patient's life and cause the spine to break down? Yeah, so inform them, educate them. It's up to you to show them what's on that and then on the image, and then how can you help? So let's go over some examples, okay? So these are real patients. This patient has headaches and neck pain, and then we'll say it started after a crash. Okay, I mixed up some of these patients. So your patient comes in and they have headaches and neck pain. Okay, something that chiropractors see all the time. Yeah, my neck and my head hurt, right? So now again, obviously you want to do an appropriate initial exam, ruling some things in or some things out, maybe need further imaging. And all that is on the site too with doing exams and stuff. So let's take a look. So here's the person's neck, okay? And this is someone was asking about posture, right? Here's a lateral x-ray. So that's my x-ray, and I have headaches and neck pain. What are you gonna tell me? What do you say, right? So you don't have to jump on here. It's a bunch of you in here, but say it to yourself. What do you say with that image? I'm getting ready to pay you because I need your help. So this is your image. This is my image that you're showing to me. And you're like, hey, I have headaches and neck pain. And you bring up this x-ray. Maybe they came in with an x-ray from another doc or 7 other docs because no one explained them. Is there anything on there that's a problem? What do you show? What do you say? So number of things that we do, and I'll show you here, is quickly and easily educate and document what's happening. So what we do in our office is I always sit with my patient, and we're going to say, and we have other images that are up here. Hey, Don, you came in after a crash and you have headaches and neck pain. So the first thing we want to talk about is your neck pain. Now, neck pain could be broad, but see the red line. The red line is where the backs of your vertebral bodies are, and it should be close to the green line. There's a normal curvature that's supposed to occur. When you have that normal curvature, most of the weight, 2/3 of it, should be on the back of your cervical spine. And with yours, and this is up on the posture A2, you lost 87%, whatever it is. So now, where's most of the weight? It went from the back to the front. And now you're loading these discs. And as you can see, there's some arthritis there, right? So you're going to look at certain things. Now, in terms of headaches, then from there, what we're going to do is, I think you can still see my screen. There's a number of different things that we can look at on the site where you can quickly go headaches. Type in headaches, do a quick search. Oh, look, loss of cervical curve and headaches. Hey, Don, this was, oh, I logged myself out. Hey, Don, you came in and you had headaches, and I just showed you your neck and how that loss of curve is a problem. Now, we see this every day in our office, but I want to show you some other stuff that your neck has been studied multiple times in lots of journal articles or necks like yours. And here's one from Medical Science Monitoring. And what they found is that necks, real similar. Here, again, here's normal. This looks a lot like your neck, doesn't it? It does. And what they found is that in order to diagnose your loss of curve, you have to measure it. And that's what we did. But it also shows that it suggests that a loss of the curve is related to a cervicogenic headache. Now, cervicogenic headaches are headaches that are coming from your neck. And what they found is that, and again, I'm familiar with this, but I also make it really simple for you to just follow along. Pretty much every paragraph will say something as it relates to the paper. Hey, look what it says here. Loss of the lordosis is associated with structural and functional negative effects in the cervical region, such as mechanical overload, degenerative changes, which we saw in your X-ray, and their X-ray is up right there, herniation and reduced vertebral artery hemodynamics, and these suggest a potential loss of lordosis as a sign of headaches. So what this study shows, as it really relates to your neck, let me pull up the PowerPoint here, is you have this significant loss of the cervical curve, as well as studies, as well as my clinical experience, show that this abnormal mechanical load will load the discs, even the vertebral arteries, that can lead to headaches. Done. Simple. Here's a study. I can print that out for you. Copy, paste, print it out. And then real simple as I show you this on how to do SOAP notes, copy, drop in his notes with the reference. It's that simple. Now your notes reflect why you believe this X-ray finding is correlated. You're not just selling it to them. You're like, look, I see this all the time, but I also want to show you a study that's really similar to what your findings are. The other thing that I do, if you haven't done this yet, I make this real quick because I have on my favorites. I know when I do a review of findings or whatever is, I have stuff that has things associated with headaches, degeneration. Hey, you also have degeneration. Hey, here's a really cool study that actually talks about when you have a loss of the cervical curve, they show that over time it causes the discs. Oops, I'm having a little trouble with my fingers here. It causes the discs to break down, leading to degeneration. And this was published in the Journal of Pain Resolution. And they found that maintaining a lordotic alignment is related to a lower adjacent level ossification disease, meaning when we start to work on your neck and we start to improve the shape of your neck curve, not only can we minimize pain because the pain is coming from this abnormal curvature, we also know that it can increase the likelihood of those discs getting and staying hydrated to minimize your arthritis. So I don't know why the other providers were telling you that your X-ray looks normal. This is something that is clearly identified both by me clinically and by some research that I already showed you. Boom, copy, paste, put it in the notes, copy, paste, email it to them. It takes 2 seconds, right? And then you could even go further and we can start to get into how it starts after a motor vehicle crash, right? So you can get into, coming out, let me get back in here. And then you can go to loss of curve, right? Like, okay, well, how do you know this car crash occurred from a loss of curve? Excuse me. And then you can obviously go to causation and look at other instances as that occurs. Does that make sense? So it's super simple. So let's go back. This is what we do in our office. Hey, Don, here's your X-ray. Your X-ray, you had 87% loss of curve. You can see, and we also have their a normal neck next to theirs. That's on there. With this loss of curve, we know that there's mechanical distress, and that mechanical stress can pull on the vessels. It can even pull on your spinal cord. And as I showed you in that one paper in medical science monitoring, that is strongly correlated to neck pain and headaches. So we're going to fix why you're having the neck pain and headaches. It's just like, and I use this analogy all the time, it's just like if you were walking around, one shoe on and one shoe off, and all of a sudden your knee, your hip, and your low back started hurting. What do you think we're going to do? Are we going to stretch you? Are we going to give you a shot, a drug? Or are we going to actually put one shoe on or take the other one off to start to level it out? That's what we're going to do here. It's going to take about 3 times a week. Maybe it might be a minimum of 40 visits. After that, we'll reevaluate you and we're going to see where you are. So sign up at the front desk and that's it. We have package deals if you want, if you want. So it just makes it super easy to document. So let's go over this one. Patient comes in and here's what we also have. Here's the normal to their normal. Patient comes in and they're like, I have neck pain with arthritis. And all the docs are telling me that arthritis is normal for my age. We all heard that, right? So you have this X-ray. What do you do? What do you say to these patients, right? Anyone want to chime in? There's a bunch of you on here, right? Don't be embarrassed. Like role play. What do you do? So all these docs are telling me my neck hurts and I have arthritis. What do you say? How do you tell them? How do you educate and inform them that it's not due to your age? So let me show you a little what I do. if no one wants to raise their hand, I got a text here, but so one, we know that age is not an exact determinant for when you're going to degenerate. And how do you know that, Mary? You have a lot of degeneration here where your neck is real kyphotic. And up here, it's the same age. So if it was due to age, would they degenerate at the same time? And then laugh like, no. So we know it's not just because of the age. So I ask a question. Whatever arthritis you have, it's going to get off with your present, says whatever arthritis you have, it's going to get with your present curve problems for sure. So, and again, that's where we're going to go, right? So we're going to talk about that. Whatever issue you have could be related to abnormal biomechanical issues. But I also just explained, hey, these discs are the same age as these. Why are these degenerative a lot faster? So I explained that to him. Real similar to the first time. When you have this abnormal curve, you lost 145% of your neck curve. Your neck is supposed to be lordotic. It's now considered kyphotic, meaning it's going the other way. It's going the same way that our thoracic spine is supposed to. Your neck is going the complete opposite way. And when you have the abnormal mechanical load, you could use the other studies like what we showed when we did Don. And now we're going to get into some other stuff here too. So let me get back into here. Someone just asked another question. Worse, sorry, that's okay. I kind of understood what you meant. And then you're going to get into explaining and showing them. So let me just show you how quickly this is done, right? So you're going to look at like osteoarthritis or whatever the case may be of what this is. Let me just, oops, hold on, get out of here. So now I come to the site and we show them the x-rays, we explain to them the normal curvature, where it's supposed to be. And now you like osteoarthritis. So you can type in OA, right? And osteoarthritis, just with typing in OA, look, here's some studies. Hey, disc death linked to increased load, not age. So when I show them this, like, look, remember we talked about the abnormal mechanical loading, you're loading the discs. The discs are in the front of your spine. They're not supposed to break down. And they're not supposed to bear weight like yours is. And we see that all the time. I give the analogies, but let me show you what this actually, take a look at this paper here. This paper was published in Spine, really wonderful journal, but look what they showed, altered cell function and cell death. It's mathematically linked to regimens of spinal loading. So when you have your abnormal curvature, copy, paste in your notes, you now have evidence that osteoarthritis is mathematically linked to regimens of abnormal to spinal loading. And the main hypothesis for the study is that excessive spinal loading creates a toxic environment for your discs due to large tissue deformations. So when we showed you look at your x-rays here, Mary, you have significantly abnormal mechanical loading. Would you agree? And look at what those studies show. It's causing a toxic environment. Now, we don't have the technology to see toxic environment on images. They do it in labs, and when people die and they cut it open, we don't want to do that to you, but you can see your neck is stuck in this toxic environment, causing the discs to break down. Now, a lot of times in our office, if we can improve movement, reduce those subluxations, increase the amount of curvature, and minimize the abnormal mechanical loading, what is it going to do to the toxic environment? It's going to reduce it because a toxic environment is there due to the abnormal loading. Does that make sense? It's the same thing walking around with one stiletto on and one off. You're going to abnormally mechanically load a side, which is going to cause it to break down sooner. So it's not the age of you, Mary. It's not you have degeneration because you're 50. It's the age of the abnormal mechanical loading leading to a toxic environment, causing your joints to break down and die and hurt. Our adjustments are going to start to get movement into that toxic environment. That's going to start to feed the joints, get nourishment in, pump the waste out, and we're going to try to mold you into a better curvature so that we get your neck into a better mechanical function. Does that make sense? Super, super simple, super easy. And then same thing. I know I have stuff in my favorites here on dashboard because these are common things that I normally see. This death, this damage, here's another one. And I'll show them. And I show my patients, look, it's kind of a gross picture, right? You're bonding with them, you show them. This is a real anatomy picture of disc. But look, this actually shows, and that's why I choose these topics. So you can show them, look, this actually shows that disc damage, when the disc gets damaged, like on your neck, the arthritis, that actually leads to more disc damage and degeneration. It's actually biomechanical. And look at what they did here. They actually ripped discs out of spines in the neck, in the low back. And this is what's great too. You could show them, hey, here's a normal disk, right? There's stuff all on all these pages. You can copy, paste, put in your notes. Um, Here's like they're pulling the annulus. But look at what they showed. And this is the problem with your neck. This is what makes me a little concerned, is that we know in the science that damage to the adjacent IVD significantly impacted the part of the disc, right? You don't have to read that. And that means that the adjacent discs in the experimental group was found to be significantly lower than that, meaning when your disc starts to break down, Mary, like it has been for a couple of years, because you didn't come to our office or whatever, that actually caused a cascade of events that the discs above it, the adjacent segments, are also less healthy and they rapidly accelerate degeneration, all due to abnormal mechanical loading. So, what do you think we need to do to stop your neck from getting older? We need to stop the abnormal mechanical loading, these true subluxations, improve the mechanics. And the beauty of it is not only are we going to get your discs healthier, we're also going to minimize the amount of pressure that's on your vessels and your central nervous system that controls every cell, organ, and tissue in your body, because that's under strain as well. And then, of course, there's studies on there that discuss that as well from vascular and other things. Right. So that's what you say. How do you educate it? And then I can show you, I showed it before and how you quickly educate, drop it in your notes. And there's tons on here under just type in soap. All right, so here's a pain, or here's a pain. Here's a patient. Hey, doc, coming in, got neck pain. You did your, you know, consult or exam, and now you have x-rays and they were in a crash and they have instability. So what do you say? Right? What happens? What do you do for that? How do you communicate what that instability is as a problem and what does it mean? Anyone want to take a crack at it? Oh, someone here is. What do you do? Oh, it's unstable. It's moving too much. That's great, but these patients are usually educated. They're going to go home and look it up. So let's take a look at some things that we do in our office to help educate and inform them. Hold on one sec. And then we also, sometimes we'll show them the numbers like, hey, it's over the normal range. This is obviously all in their notes, like, hey, this is how we know it's unstable if you want to take it a step further. But then I start to explain what is instability, right? So how do I do that, right? How do I explain to them what instability is? So hold on one sec. So from here, sorry, I got a little light in the way. You could easily go to instability, right? It's from a crash. How do you know the crash caused it? So let's just start with that. Hey, John, you have instability in your neck after the crash. I do believe this was from the crash because of, and again, that's where history comes in. But then you're also just going to go straight to causation. And there's going to be tons of information about instability and causation. How does instability occur? Trauma, crashes, other types of stuff like that. And then look, here's a bunch. I don't know, I'll just pick one. Oh, look, loss of ligament strength after a motor vehicle crash. Oh, here's a study that talks about, blah, blah. We know that car crashes, it's been very well documented that car crashes cause your ligaments to get disrupted. They start to buckle, they start to break down, the ligaments get disrupted, and now your joints are moving too much. And then you could just go to the symptomatology that they have, that maybe they have neck pain, maybe they have arm pain, maybe it's neuro, maybe it's vascular instability, and let's say they're having some neurovascular compromise. You're going to quickly come to here that talks about, it's right here for you. Drop on this. Hey, John, here's a study where they looked at instability and they took a look at what's happening. Look, when they did flexion extension, instability occurred in this many percentage times in patients in crashes and only 3% in those not. We know that this is strongly correlated to a crash that you were involved in. We measured it. You're over the normal. That's why I have to talk about instability. And then, of course, I have in my, under my dashboard, I click on favorites. I change this all the time. I'm going to have a bunch of stuff in here about, okay, here's one, cervical buckling and impact. car crashes cause buckling, right? And you can quickly just copy, paste, show them, print it out, have it at the front desk, email it to them. And I talk to them. Hey, John, you're involved in a crash. We came up with instability. You're having neck pain. On your physical exam, it showed ABC, whatever you found. This correlates to your findings. We also understand that this abnormal movement is leading to the joints breaking down, and you're also having whatever it is, neurovascular, whatever it may be, right? Let's say, and in this case, it's a neurovascular symptom. So you can come right to instability, go to neurovascular, and then you're going to correlate the neurovascular findings to their images, to their symptomatology. Hey, here's one that actually talks about how the instability leads to neurological deficit. And that neurological deficit leads to pain and some of the symptoms that you're following, that you're complaining of. That's one of the reasons we are going to start to work on stabilizing your neck, strengthening it, adjusting the areas that aren't moving correctly. And as you can see here, some of your vertebrae slip backwards. We're going to be able to adjust those forward. We're going to adjust those from a back to forward position. Does that make sense? And it's starting to use the communication. What do you see? What do you see that's wrong here? Why do we take these x-rays of your neck? Look, John, we had to check the structure and stability. And in this case, you had abnormal stability. What is abnormal stability? Well, the joints are moving too much. Those joints are moving too much can lead to neurovascular, and we show them. Well, let me see what this says here. For pain, everyone always thinks it's from tight muscles for sure. I tell them that altered motion creates more work for the muscles, and that's why they tighten up. What do you say to address muscle tightness pain that they aren't where all the symptoms were coming from? It's great for sure. And I think, let me show you. So a lot of that, patients will come to like, muscles are really tight. My muscles are super tight. So I give them a couple scenarios. I have this little octopus, this little glass octopus on my desk, right? It's like a paperweight. It's not very heavy. You could get a book, you can get a water bottle. And I say, look, you're talking about your muscles, the problem when the muscles are tight. Let me explain to you a little bit about what's happening here. And you say, okay, you went over your x-rays, you showed them what the normal shape of their neck is supposed to be. And you say, okay, so your neck is supposed to be back. You have this abnormal curvature, correct? So what's happened? Let me just show you here. I'm going to pull this up so I can show you on this, let's say on this x-ray here, just for, hold on one sec, just for this person here. Okay, so perfect example. So you see how much forward this is compared to here? That's a pretty significant space for the spine and spinal cord. So what I want you to do is hold this octopus, and I have them, I have them hold it right here. I'm like, hold it right here. And I have them get right up against their chest as close as they can. And they're like, I'm like, is that heavy? And sometimes they say, yeah. Or sometimes they're like, not really. I'm like, great, now do this. And I make them hold it out. And then I'm like, is that heavy? And they're like, yeah. I'm like, it's the exact same weight. But what's happening to your muscles? Your muscles are contracting to stabilize what's happening. So what do you think is happening to these muscles here? They're being overstretched. And when the muscles are overstretched, due to the structural abnormality, what do you think happens? It's contracting. So the muscles are only acting, and I'll show you here, are only acting due to, in a lot of cases, due to abnormal biomechanics that are causing the muscles to spasm. So when you stretch the joints, like here's one here, it talks about thoracic kyphosis, right? So this is muscle activation. And what they did is look at the muscle activation just by changing the shape of the spine. The muscles have to contract. It's not due to the muscles are tight. They're tight because the joints are a problem. The muscles hurt because they're contracting all day to um, to protect the abnormal movement and the instability. And then I just, you could type in muscles and there's all sorts of stuff that comes on here to talk to them about that. But that's the beauty of this site is to discuss, like they should have questions. I was told this, that's cool. Let me show you why that's not completely accurate. And if that was true, then all we have to do is give you a muscle relaxer and your symptoms will go away. But what do you think will happen if you're trying to stabilize and now we make your muscles weaker? There's going to be more destabilization, which can lead to more problems with the joint. And that's just how we discuss it. And there's studies in here like that one I showed you. Here's one that's really great that talks about this abnormal neck curve. And you talk about this, look at what it says here. This contributes to eccentric spinal column loading and an exaggeration of the loads applied to the cervical spine. Additionally, patients with cervical kyphosis have limited cervical flexibility. The muscles are tight due to abnormal loading. And then you just come down and you show them this, right? Look, I have all sorts of, this from Journal of Neurosurgery. And look at what they showed, that having a normal neck curve, your neck can withstand more force for a period of time compared to even just straight. And Mary, your neck isn't straight, your neck is kyphotic. It fails quicker. And then it's going to be tighter because it's the loads and the forces being applied that's causing the muscles to contract. So we talk about this all the time, right? So it's using, because look, patients they're already in your office. They're going to get educated. They're not there to get sold like, oh, well, it's because the subluxation is causing the muscles tight. They're like, that doesn't make sense to me. Totally. Let me explain to you how this works. Look at what it's doing to your muscles. This is a study that I rely upon to give you the best possible care from Journal of Neurosurgery. That loading the lordotic spines, which is what your neck should look like, it can withstand the compressive load. But when you lose it, look what happens. Everything shifts forward, everything contracts, and it's trying to stabilize a region. Your muscles are like cables on a bridge. And all of a sudden, if the bridge starts to tip, what happens? Some cables are going to get really tight and others are going to be flopping around because they're not being called into play. What you're doing, all these muscles back here that you're stretching, they need to be contracted. They're trying to stabilize your neck. Let me see here. Sorry. I'm gonna you're gonna get an octopus, a little glass octopus. And using these analogies mixed with the research is incredibly powerful. It's how we built our practice. It takes time, but no one else is doing it, or very few are. And patients are running out of patience. They want answers. They want to see, does this make sense? Explain that to me. Don't sell it to me. I already heard. What can you do and how does this make sense? So let me go to this one here, because this one is actually really interesting. So hopefully I described the instability, right? It's all the same thing. You see where I'm going. I have some LinkedIn favorites. I go back and forth. I quickly just type up and stuff's going to pop up that even if you're not aware of it, it's going to make sense. So you won't look like you're bumbling around. You're like, oh, look, here's another paper that discusses this. So this is a cool one. Let me show you this one here. Because this just happened. This patient flew in from Texas for a few weeks for care. Chronic fatigue, fibromyalgia, fatigue, dizziness. We did a flexion extension. We did a full DMX, but flexion extension. And I put arrows when I see some crazy stuff if there's not a red line. What's happening there? What do you see? Anyone want to take a stab at this? Come on. Tell me, what do you see? If you see that, what do you do? Is that a problem? What do you tell a patient? So someone hop on. I got a couple of texts here. You say something about the transverse ligament. So what do you say about that? Are you right away going to send for a surgical consult? That's up to you. Not telling you should or you shouldn't. A lot of these, even if you send for a neurosurgical consult, they're going to come back to your office. Like, it's not surgical. It might hurt. It's a ligament injury around the upper cervical spine. Oh, let me see. Hold on. Someone's getting brave. That's an indication of ligament damage that needs more evaluation. Okay. So, and it may need more evaluation, but what ligament damage does it show? So chronic headaches. So let's take a look. I'm going to back out. And here's how I use it. So you see upper cervical. Let me do this here. We'll go from this one. Right. So we did this, and then we had an MRI. And what do you see here? There's obviously a big gap, but look at the white. That's increased fluid signal, right? That white shouldn't be there. So we know that there's some damage, and then we did a DMX and showed there's some upper cervical instability. So what do you do here, right? How do you educate that? Let's say you've evaluated. You did a X-ray, maybe you did a DMX, MRI, and this shows this. And she's been being treated by all these people forever, neurosurgeons. How do you address this? in the same manner, right? So you're going to go back. Hold on one second, I'm gonna get something to drink here. And go to instability. And right at the top, right now, we'll be putting some new ones up here soon. Look, ADI space. You can type in ADI, transverse ligament. Is it age dependent? And in some ways, it actually is. The older they get, the less space they should have. That's a whole other thing I'm going to do a webinar on here. But the magnitude of ADI decreases with advanced age. So if you get someone at 50 years old, 60 years old with 2.5 millimeters, that might be in instability as opposed to 3.5, right? Science keeps changing. That's the beauty of it. Here's another one: transverse ligament injury and motor vehicle crash. Right. Oh, look, were you in a crash? Did you have a trauma? Yeah. This is not an uncommon area to be hurt. We look at this all the time. I don't understand how this was missed. I don't know why they didn't see this. But what they looked at was damage of the transverse ligament on imaging. And this was from European Spine Journal. And they found that upper cervical injuries get damaged, the ligaments. Then if you want to go to headaches, right, you can do the same thing here. Let's say before, you can do MRI, right? And you're going to type up MRI. Here's a bunch of stuff: WAD, MRI, everything on MRIs that you can look at, right? Oh, look, here's one: transverse ligament injury and motor vehicle crash, right? Here, like, all of it is right here to quickly search, quickly find. But let's say they're having headaches. What's the upper cervical spine? Maybe it's the myodural bridge. We talked about that. So type in myodural. And look, a myodural bridge, what happens? Chiari, upper cervical anatomy. And look what they show. The suboccipital region is one of the most complicated areas in the human body. And we show them this, talking about the tectoral membrane. And we show that I use this one a lot. And I'm like, hey, Mary, I hope you're not grossed out, but this is a cadaver slide. Remember on your MRI, this is where the white space was. This is C1. Here's your brainstem. This whole region where it's unstable, these muscles, your rectus capitis posterior minor, rectus capitis posterior major, these start to invaginate into the cord, into the dura. So imagine what's happening when your neck is forward, you have an abnormal curve, you're stressing this, you're irritating this myodural bridge. It's going to stay irritated and give you headaches. So our goal is to try to stabilize it, get your neck in a better position with maybe with different tractions, exercises, and and show them this is not uncommon. I don't know why people miss this on you, because we see this every day. And then the other thing that, is looking at those regions of how do you get them better? What can you do? How do you improve them? So you're not trying to be a personal injury doc. You're just trying to be the best doc and quickly use it. So with this patient, hey, Joni, you've been suffering for a long time. A lot of these docs saw these images. Here's your X-ray. First thing we notice here is this abnormal cervical curve. And when you look down, and on your exam, it seemed like looking down gave you some problems, you have this increased space of the bones. And that signifies that what's called the transverse ligament is disrupted. And let me show you here, transfer, you type it in. This is something that's been shown to happen in these types of traumas. But also let me show you how this is correlated to your upper neck, around your brainstem, even your what's called your myodural bridge, that's causing these headaches. So we're going to get to the root of the problem. A lot of people diagnosed you, told you with headaches. These headaches are coming from this abnormal spinal alignment, which we also call subluxations. And we're going to try to get this better the best we can. If we need to send you for different imaging or maybe even different care, we're going to do that. But I believe we identified what happened. Let me show you some other stuff here about how this relates to you, your central nervous system, so on and so forth. And you were also diagnosed with fibromyalgia, is that right? So fibromyalgia is basically just a gigantic term that discuss fibro, my muscles, algia hurt. All my fibers and muscles hurt. I want to know why. Is there any correlation? Look, do you guys know that this paper is on here? This is from American College of Rheumatology, and they actually found they were able to tell with 121 patients just by looking at their necks that patients with an abnormal cervical curve had fibromyalgia. That was like the biggest diagnostic factor. So you were diagnosed with fibromyalgia, but according to the American College of Rheumatology, they found that a straight cervical spine can be used to assist in the diagnosis, meaning fibromyalgia, things hurt, is correlated to your abnormal cervical curve, and your abnormal cervical curve is linked to your central nervous system, the vasculature, all this other stuff. So we're trying to get you into a better curve. That's not going to happen overnight. You need to come in and stick to our treatment plan so we can restore that and get into a better position. Does that make sense to you? Yeah. Okay. Is there anything here that I mentioned that you would like to see again? Yeah. Can you show me that? Can you send me the thing with loss of curve and headaches and tissue irritation? Absolutely. I come on here, all this stuff, I copy, paste with the reference, and I'll email it to them. I want me to print that out for you with my name on top. Sure. You have other friends that you've been in Facebook forums with people suffering from this. Yeah, please go ahead and put that on there and give them my name. Boom. That's I don't want to say how simple it is because it's hard work, but you have to increase the level of your practice to continue to get people to tell people that you're doing something no one else is. Does that make sense? So I don't want it to look hard. It should be, it's work. If you don't know what the hell you're talking about, it's going to be hard, right? If you're just like, oh, your neck is not in the right position, and then they're like, well, how do you know? And you're like, well, it's because I know. Like, no, show them. Like, patients are incredibly smart people. If I went like, I'm not smart in computers and stuff. If I went, I was like, I'm having a computer problem. I want them to like, okay, this is what you're doing wrong. Like, tell me because I have no idea. They're there because they're having an issue and they want answers and they want to be informed and educated. That's my experience. And that's how our practice has thrived and why we're busy and why we have a 3-week wait to get in and we're not on any insurance networks and we don't charge $20. Educating, showing them. So right now, what do you do? Right? Let's put you on the spot. How just no one's going to hear you, right? There's a bunch of you on here. So this is I come to you and I have neck pain and people told me I have arthritis. Take I'm going to time this. Take 45 seconds right now and just talk to the person sitting next to you. Talk to your patient. Hey, Mary, what do you say? How do you use the site to show me? All right, so go. We'll do 30 seconds. Just get used to saying, boom, get it going. Get it going. I'm going to shut up so you can. Okay. Now they don't believe you. Yeah, I don't know. I heard that like there's really no, everyone has abnormal curvatures and it doesn't really matter. What do you say to that? Right. That's when I'm like, look, and that's when I don't like, I'm not here to argue with anyone. Someone is like, oh, I'm being cocky or arrogant. Like, I'm not. I'm just trying to figure things out. Right. So I just use the site. And I'm like, look, I totally understand they say that. However, there's really no truth to that. So what we do see is this, like loss of cervical curve. There's a lot of evidence here, Mary, that it's dramatically linked to central nervous system irritation. There's a diagnosis code. Here's a paper that was published in Journal of Orthopedic Surgery. And look what they say, that cervical sagittal balance is presented and includes key radiographic clinical eval techniques and surgical decision making. They want to do surgery on your neck. Look what it does to your neck. Tethering of the cervical cord can produce increased intramedullary pressure. Tethering of the cord is due to that abnormal curve. Intramedullary pressure can cause headaches. We need to address that. Someone just asked something here. Get used to talking to them and seeing how that can inform and educate them. Can you see that your curve is abnormal? Yep. Research shows, yep, show that this effect now and later. Yep, not my opinion. It's published. Exactly. You could say it's my clinical experience as well as it's very published. It's just like, think about scoliosis. You know what scoliosis is, right? Is that a problem? Well, all we're doing is you're taking your spine and tipping it. Here's an abnormal movement of one segment. It's instability. Is answering like all of their questions to inform them, not to sell them, hey, those are great questions, but here's some evidence from Journal of Neurosurgery, Journal of Orthopedic Surgery, whatever it may be. I want you to have this. And I encourage my patients, like, you should question me. Like, question me. Like, I want to give you, everyone else is giving you some weird, like, that's my opinion. Oh, that's this. Show them. explain to them, educate them. They are there to spend good money in your office to get a great quality of life. They want to ask questions. They want to learn, right? Like just, I don't know what my chiropractor's doing. I mean, how many of you have gotten chiropractor or patients that have seen chiropractors for the last, you know, 6 months, 1 year, 3 years? And this is another clinical pearl that I say, and I say this to every patient that has come to me that has seen multiple providers, whether it's surgeons, whether it's chiropractors, whatever. I'm not picking on chiropractors, of course. They come in with all this stuff. There are X-rays, there's all these abnormal curves, there's instabilities, like true subluxations. This is one thing I always say. I am not questioning you. This is actually more of a question for your providers. But can you tell me what's wrong? Like, do you know what's wrong with you? And they look at me 99.8% of the time. They're like, I get like nerve pain. I'm like, no, no. What's wrong? Why are you having these problems? Oh, well, they say I have arthritis. Yes, you have a lot of arthritis, but what is the problem? Do you know why you have arthritis? Because my age. And then we go into it. Oh, I have a disc herniation. Totally. Do you know why your disc herniated? No. They never, all they want to do is a cortisone. Sure, they want to try to cover it up and get you out of pain. That's important. But do you know why? Do you know why that area is not healthy? Use the site. Go to discs, instability, whatever it may be, right? Like that's how we use this site every day. So as a goal or as a challenge, try to use the site every day, right? Start using it. And then you, for your patients, have it up, print some stuff out. And then once a week, just listen to one of these. This one's only 5 minutes long. Listen to one and be like, oh my God, I want to listen to what this is actually saying. I want to hear what this says. And it just gets you better. And then the next time you go to the office, you're like, no, that was a really cool paper that talked about irritation of the spinal cord based on this. Now you have that knowledge in your brain. Oh, next week I'm going to listen to another one. So, do any of you want to see a really crazy image from today? For all of you that are on here, I want to show you this here. All right. So, get ready for this one. I'm going to pull this up. I don't want to share my screen in case I think I took his name out of it. Okay. So, hold on one second. All right. Hold on one sec. You ready for this one? So, this is a dude, a guy. Hold on one sec. That So this is a guy who's a lawyer and he got referred in for an image and riding his bike and he fell 20 minutes, 20 miles from help and he fractured C2. And this was 5 years ago. And he couldn't move his neck. He couldn't look down to see what gear he was in. And he gets surgery. And it's a weird surgery. They put a screw through dens. So he sees some providers, they do MRIs. He has headaches, right? Just headaches, no neurological. Well, headaches, I guess, can be neurological. And his provider sends me this to do a DMX because they had MRIs and CTs. And like, we think it's a non-union, but check this out. Um, all right, you ready for this? Just see if you can. Okay. All right. So first of all, this guy's neck is super buckled. Um, Obviously he's got significant anaerolisthesis, but here's the screw. So watch right here, right? There's a screw through the vertebral body into the dens that should be fused. Like, how does that, even if it doesn't fuse, shouldn't the screw be holding it in? It's been 5 years. So remember what we talked about, the mild dural bridge. We talked about, but okay, so watch. Look at right here. Watch right here. Look, ready? So how is it moving that much with a screw through it? And watch it go slip forward. Clunk. So, and then watch here again. Ready? Look at it clunking back and forth. Hold on, ready? clunk. And then we do all of his joints. They're all, I mean, the facets, everything is, oh God, so bad. But he doesn't get a lot. He gets some overhang, but watch this periodontal space. I mean, one, the dens is kind of crooked. Um, so yeah, kind of a, that was a weird one from, we had two really, we had that one today. And then we had this one today too. You ready for this one? This was both today. Ready for this? Check this one out. Look at that. Look how far that is. That was collared. Yeah, look. Both of these were today. And notice like zero extension. But this was both we saw today. So anyway, someone, let me just see here. Someone had a question. Yeah, holy crap is right. Isn't that crazy? Yeah, both of those. So, and again, those were referred by just educating this way, right? Educating this way, showing what we do. It didn't have anything to do with the DMX. It's these patients looking for answers. That's how, in a nutshell, that's we educate. If you're still logged in, and again, this is up 24/7, 365, we'll put it up. Watch how we do initial exams. Just type in initial exam. There's tons of modules of upper cervical exams, facet exams, disc exams, loss of curve exams, how we document it, how we use the site every day. So I just challenge you all to fight crazy hard to get better. And once you realize that, I promise you, your practice will grow. Does it take time? Yeah. Am I going to sell you easy buttons and value drivers? No. I just want to try to get us all better because I truly believe what we do as chiropractors, no one else can fix those curves. No one else can fix those subluxations without fusing them, and then they're fused. No one else can minimize the tension of the spinal cord and the nervous system. But all the evidence is on the site to suggest why that's possible, why that's a problem, and what we can do. And that's the whole goal of my site. So if you find this to be helpful, please keep using it. Please tell other people I'm just trying to grow it because I know what our profession is capable of. And I hope my site reflects that positively. So I feel like it's reflected positively in my office, and I just want all of you to use it. But you have to get used to using it. Whether you just listen to the videos and you start to speak it, make handouts, show it to your patients, make sure you're taking that information to put in your notes so that your notes reflect what you're doing. And yes, that's a crazy plant behind me that goes all the way around and around and around the room. My wife has a crazy green thumb. So anyway, I hope you found that informative. I'll give you like 30 seconds if anyone has more questions, but quick, different scenarios, different ways to address it. Because again, I'm not going to give you a simple script. Every patient is different. Look at those two DMXs that I showed you. I don't have a script for that. Look at each one of those with the increased ADI space, the loss of curve, the tension, the instability. There's no script. Those are serious subluxations and pathologies that they want to be informed and educated on what it is. And be the one to do it that does it. So anyway, I love you all. I love our profession, and I look forward to doing more of these. If you have any uh, suggestions of other ones that you want to do, please let me know. Thank you that you thought that was great. I hope that was informative. This will be up really soon. And yeah, any other topics that you want to know or go over, and I might do another one for this, like maybe going to MRIs more or DMXs. There's some that are already on there, but you just tell me if you want more patient communication. I already have videos up there with consults. Let me know. I want you all to thrive. Like that's the whole goal, and our profession should be the one that's thriving. Because I do believe we have pretty much the most to offer. Yes, on MRI, sweet. I'll get some MRI ones up here. Oops, and do some MRIs. Also, go on there and type. I do have a bunch of let me show you here. I do have some webinars that are up here that, and again, I'm not saying this to not do an MRI one. I will, but we do have some webinars on here. With MRIs, like if you go to some of these webinars, some of these either med legal or even the clinical webinars, there's ones on here where we go through a bunch of imaging, and a lot of them do have MRI and MRI findings and MRI discussions that we really go over. Like you could see here's one of upper cervical imaging. Here's one diagnosis and diagnosis codes. Here's one where we looked at ALL, imaging and diagnosis. Here's another one, imaging upper cervical instability. Here's webinar, so that we have a bunch on here. And then of course you could always just go to, and here's another one we did. Here's another webinar of, looking at X-rays and MRIs. And then of course you could just do MRI, and then a bunch of stuff comes up. Here we go, that I've done MRI findings and motor vehicle crash and MDC next with CSF flows if there's differences. So yeah, I'm here to help. I know there's a ton of content on the site, but keep using it. And yeah, this will be up soon. And I appreciate you all. Have a good rest of the night. Hope it's not nearly as windy or cold where you are as it is here in Colorado. It's been nuts. And everyone, I'll talk to you all soon. I super appreciate you all logging in. Thanks so much.